Hello and welcome. In this video, we will give an overview for conceptual understanding of ovulation induction in infertile patients. The learning objectives include identification of the indications for using injectable drugs, understanding the different types of drugs, explaining the mechanism of action of these drugs, discussing the role of adjunctive medications like human chorionic gonadotropin or HCG to trigger ovulation and GnRH antagonists or agonists to prevent premature LH surge. Briefly, we will outline the protocols for injectable ovulation induction and explain how to monitor ovarian response through ultrasound and hormonal assessment. Before we go on, let's just briefly go through the history of ovulation induction. So it's about 100 years ago when scientists confirmed that FSH and LH were responsible for the development of the gonads in animals. And FSH and LH was subsequently extracted from menopausal urine. In 1958, the first ovulation induction was used with the help of human pituitary gonadotropin, and the first pregnancy was reported in 1960. Clomiphene citrate was introduced in 1953, and in the 1980s, a pure form of FSH was also introduced as a result of recombinant technology. Letrozole was introduced in 1991 for breast cancer, and in 2001, it was patented for ovulation induction. The primary indications for injectable ovulation induction include anovulation or oligoovulation, polycystic ovarian syndrome, assisted reproductive technology, for example, IVF, hypothalamic amenorrhea, and unexplained infertility. The types of drugs that are included as injectable ovulation induction are the following: human menopausal gonadotropin, where the source is urine from menopausal women; Follitropin or pure FSH through recombinant technology; gonadotropin releasing hormone, which comes in two different kinds called agonists and antagonists. These drugs are used to control the release of luteinizing hormone and preventing premature ovulation during controlled ovarian stimulation. In addition to these drugs, clomiphene citrate and letrozole is also available in the injectable form, although not worldwide. And human chorionic gonadotropin trigger is typically given as a single injection to trigger ovulation once the follicles have reached an adequate size. It is extracted from human placenta and it contains large quantity of luteinizing hormone and also some follicle stimulating hormone. Human menopausal gonadotropins are the most commonly used ovulation induction injectables. The basic vial contains 75 units of follicle stimulating hormone and 75 units of luteinizing hormone per ml. Although the concentration may vary among batches, and this range may be between 60 to 90 units for FSH and 60 to 120 units for LH. Urofollitropin contains 75 units of FSH, and recombinant luteinizing hormone may be added to recombinant FSH protocols as an alternative, particularly useful in patients with hypothalamic amenorrhea. Human menopausal gonadotropin is the most commonly used induction agent, And there are different protocols with which we use this drug. There is the conventional protocol where the drug is started on the second or the third day of the menstrual cycle, and the patient receives the drug until the follicle is large enough to be triggered. Then there is a step-up protocol, which is where the initial dose is low and gradually increased. A step-down protocol where the initial dose is high and gradually reduced. And then there's a combined protocol with the human menopausal gonadotropin and follicle-stimulating hormone Follitropin. Then there's an antagonistic protocol and an agonistic protocol with the GnRH, which are the GnRH agonist is a long protocol. And then there's a mini human menopausal gonadotropin protocol where a very low dose is used, and it is also used with the oral tablets and a sequential protocol. So these are used again with oral tablets. So there are several advantages of using human menopausal gonadotropin, and these include a balanced hormonal stimulation, because human menopausal gonadotropin contains both FSH and LH in balanced proportions. This mimics the natural hormonal environment, which can be beneficial for women who need both FSH and LH to stimulate follicle development. It also allows an improved follicular development because it helps in the maturation of the ovarian follicle, which may improve the chances of developing mature fertilizable eggs. There is a lot of versatility of use of this drug, and it can be used in various fertility treatments, including ovulation induction of women with anovulation or oligoovulation, as well as in controlled ovarian stimulation for IVF. Other advantages include the fact that there is established efficacy and safety because of the long history of use. There's customizable dosage, allowing flexible dosing, which can be tailored to the individual needs of the patient. And it is also cost effective. It's one of the most widely used agents which is available for ovulation induction. These advantages make the drug a valuable option in fertility treatments, though the choice of medication always depends on the specific needs and circumstances of the patient. There are some disadvantages of using HMG, and this includes the risk of ovarian hyperstimulation syndrome. This risk is present for all kinds of ovulation induction agents. In some, this risk is high, and in some, this risk is low. There is a higher likelihood of multiple pregnancy. There's a risk that patients might find it uncomfortable or difficult to manage the injectable agents by themselves. Sometimes patients are needle phobic. And there is a requirement for frequent monitoring. This obviously puts a lot of financial burden on the patient. There may be a variability in response, and this response may vary significantly between patients. There is complex dosage adjustment because it contains both FSH and LH in fixed ratios, which can limit the ability to fine-tune the dosage to meet the specific hormonal needs of a patient. In some cases, more precise control over FSH and LH levels might be required, which is easier with recombinant FSH or LH products. Although HMG is often less expensive than the recombinant FSH, the overall cost of treatment can still be significant, especially if multiple cycles are required. The associated cost of monitoring and clinic visits can also add up. The psychological stress is always present for each and every kind of injectable or even oral ovulation induction strategies. Follitropin is a recombinant form of FSH which is produced in the laboratory. It mimics the natural FSH hormone produced by the pituitary gland. Follitropin binds to FSH receptors on the surface of granulosa cells in the ovaries. This binding triggers the activation of intracellular signaling pathways, leading to the production of proteins and enzymes that promote follicular growth and development. As the follicles grow, they produce estrogen, which plays a critical role in the maturation of the oocyte. The increased estrogen levels also help in the thickening of the endometrium, preparing the uterus for potential implantation. In natural cycle, the surge in LH triggers ovulation. In assisted reproductive treatments, Follitropin is often used in combination with either human chorionic gonadotropin or with LH to mimic this surge, leading to ovulation. In IVF or other fertility treatments, Follitropin helps stimulate the development of multiple follicles, thus increasing the chances of retrieving multiple eggs for fertilization. It has a high potency and a high purity and consistency because it is used in it is produced in the laboratory through recombinant DNA technology. There is a high level of purity of the drug, and thus there is a reduction in the variability seen with the urine-derived gonadotropins. It also allows for precise dosage as the drug has a standardized strength. It seems to have a slightly lower risk of ovarian hyperstimulation syndrome, but this complication is always present in all kinds of ovulation induction agents. There is improved follicular development and reduced immunogenicity because of the lower risk of causing immune reactions compared to some urine-derived products, as it is free from human protein contaminants. Other advantages include ease of use, as it is available in pre-filled pens, which makes self-administration more convenient. It has been widely studied and tested through well-documented clinical trials and real-world use. It is more flexible in treatment protocols because of the standardized dosage, has a long shelf life and stability, lower risk of contaminants, and customizable treatment. There are certain disadvantages of using Follitropin, and these include cost. This can be a significant burden for patients, especially those who need multiple treatment cycles. Risk of ovarian hyperstimulation is still present, and multiple pregnancies. Other disadvantages include the need for frequent monitoring requirements, some variability in response from patient to patient, psychological stress, and the potential for overstimulation. Induction is a key treatment strategy for patients with polycystic ovarian syndrome and with ovulation. Several strategies are used for management. Pharmacological management includes clomiphene citrate, letrozole, metformin, gonadotropins, in vitro fertilization, and rarely ovarian drilling. When we use gonadotropins, we find that pure FSH treatment is another alternative for patients with PCOS who are clomiphene resistant. If we start pure FSH at 37.5 international units per day subcutaneously, and the dose is increased very slowly until follicle development is detectable based on an elevation of the estradiol levels and the presence of follicle development on sonograms. Using this small amount of FSH, the patient will generally develop 1 to 2 follicles, decreasing the risk for multiple pregnancy and eliminating the risk of ovarian hyperstimulation syndrome. Pelvic ultrasonography has become an important tool for monitoring of ovulation induction. The quality of the cervical mucus can be improved with the administration of a small dose of estrogens, or the problem can be bypassed by intrauterine insemination. If the follicle is smaller than 18 to 22 millimeters at the time of ovulation, a better size can be obtained by starting clomiphene citrate therapy on the menstrual cycle, day 2. Luteinized unruptured follicle syndrome can be prevented by the administration of human chorionic gonadotropin once the follicle reaches 18 to 22 millimeters in diameter. Progesterone deficiency can be corrected by the administration of progesterone during the luteal phase, starting 48 hours after ovulation. In cases of hyperprolactinemia associated with an ovulation, the management is a little different. Patients with hyperprolactinemia need a thorough evaluation to exclude pituitary microadenoma. The patient must be treated with bromocriptine, and the dose is increased gradually as the tolerance is built up. If the gastrointestinal symptoms will persist, the medication can be administered intravaginally. Alternatively, cabergoline can be used orally or vaginally, as it is associated with fewer side effects but is more expensive. Patients with adrenal hyperplasia and other disorders can be treated with prednisone, and with hyperthyroidism or hypothyroidism treated accordingly. Weight reduction may be a part of the treatment if that is the indication. It will help the patient's response to ovulation induction. Human menopausal gonadotropin is the treatment of choice for patients with primary amenorrhea due to hypopituitarism. But generally, the response is too brisk or delayed, and predicting whether the patient will respond easily is not possible. The risk of ovarian stimulation syndrome and multiple pregnancy is heightened. Therefore, it is better to start with a minimal dose and then gradually increase the dose. On the 7th day, estradiol measurements and ultrasound measurements are performed. If the estradiol levels are below 100 picograms per ml and the ultrasound shows a small follicular development, then the human menopausal growth gonadotropin is increased to 150 international units per day for an additional 5 days. In countries where estrogen levels are not available or are avoided to reduce the cost to the patient, the gynecologist will make decisions based on the number and the size of the follicle. The ideal response in primary amenorrhea is that there should be a development of only 2 to 3 follicles. However, if the response is exaggerated with more than 5 follicles and the estradiol levels are very high, then it is better to cancel the ovulation to avoid the risk of ovarian hyperstimulation and a high order of multiple pregnancy. In current practice, an alternative for patients with more than 5 sizable follicles may also be to convert the treatment to IVF. Now we will learn something about gonadotropin releasing hormone. These hormones are used in fertility treatment, and the chemical structure is a decapeptide that plays a critical role in the regulation of the hormones. Gonadotropin releasing hormone is naturally produced by the hypothalamus in the brain and released in a pulsatile manner. It stimulates the anterior pituitary gland to secrete FSH and LH. These hormones are crucial for the development and maturation of ovarian follicles and for the induction of ovulation. Gonadotropins will directly stimulate the gonads to produce sex hormones and gametes. This stimulation is in 2 types, either as an agonist or as an antagonist. An agonist will initially stimulate and then suppress the production of gonadotropins by acting on the pituitary gland. But the antagonist will directly block the action of GnRH, preventing the release of FSH and LH, leading to a rapid decrease in gonadal hormonal production. The agonists and the antagonists both are used to control the timing of ovulation and enhance the chances of successful. GnRH agonists will first stimulate the release of FSH and LH, leading to a flare effect. However, with continuous use, the GnRH agonist will downregulate the GnRH receptors in the pituitary, leading to a decrease in FSH and LH. This suppression prevents premature ovulation during controlled ovarian stimulation. Later, FSH or human menopausal gonadotropin is administered to stimulate the ovaries and to trigger ovulation. On the other hand, the antagonist will work more quickly than the agonist, and they will immediately block the GnRH receptors in the pituitary, preventing the release of FSH and LH. This direct suppression allows for more flexible treatment protocols and reduces the risk of premature ovulation. After follicular development with exogenous FSH or HMG, ovulation is triggered with HCG injection. Here we are going to briefly mention ovarian hyperstimulation. This is an iatrogenic condition that occurs in patients undergoing ovulation induction with HMG or controlled ovarian hyperstimulation for assisted reproductive technologies. Technically, ovarian hyperstimulation can also occur with clomiphene citrate as well as letrozole. The incidence will fluctuate depending upon center to center because it is iatrogenic. The pathophysiology of the disease is not that well understood, but there is a massive extravascular accumulation of fluid which occurs and there is severe depletion of the intravascular volume. Subsequently, this is responsible for dehydration, hemoconcentration, and electrolyte imbalance. This syndrome can be mild, moderate, or severe. In the mild form, it is characterized by ovarian enlargement up to 5 to 12 centimeters in diameter, minimal ascites, and weight gain of less than 10 pounds. Moderate ovarian hyperstimulation is characterized by ovarian enlargement of 5 to 12 centimeters in diameter, moderate ascites, nausea, vomiting, abdominal discomfort, and a weight gain greater than 10 pounds. Severe ovarian hyperstimulation syndrome is characterized by easily palpable ovaries per abdominally, severe ascites, nausea, vomiting, diarrhea, shortness of breath, hydrothorax, peripheral edema, oliguria, hemoconcentration with a hemoglobin level of greater than 16 grams per deciliter and a hematocrit of greater than 48%, and the creatinine levels may rise to more than 1.6 milligrams per deciliter. Renal failure and thrombosis can occur if the patient is not treated correctly. Some patients have a higher or a greater risk of developing the syndrome. These are usually young patients with a history of polycystic ovarian syndrome or oligoovulation who responded with elevated E2 levels and multiple follicles, and patients in whom the ovulation has been triggered by the administration of exogenous human chorionic gonadotropin. E2 level means estradiol levels. Recent systematic review of the literature indicates that the use of natural cycle for IVF or the use of gonadotropin releasing hormones may decrease the chances of ovarian hyperstimulation. However, more scientific data is required for GnRH to use to make definitive conclusions. If you're interested in this topic of ovarian hyperstimulation, please note the reference below. With this, we come to the end of the video. If you like the video, then please subscribe to the channel, press the like button, share with colleagues and friends, send your comments, and press the bell icon to be notified of future publications of videos. Thank you and goodbye.